And now the next and final topic would be whether in the treatment of hypercalciuria we only have thiazide. Well, we know that hypercalciuria is a metabolic anomaly characterized by the excretion of large amounts of calcium in the urine. It is considered hypercalciuria if it is greater than 4 mg per kilo in women and 4.5 mg per kilo in men. And this hypercalciuria not only predisposes to a higher risk of nephrocalcinosis or kidney stones, but it also predisposes to a decrease in bone mineral density and consequently a higher risk of fractures. Well, the recommendations used for hypercalciuria, as we have seen before, are not only medications. They can also be hygienic dietary measures, mainly then to restrict or limit a bit the consumption of sodium and animal protein in the diet. But it has been observed that calcium intake should not be restricted. A normal intake should be maintained, because if we impose severe restrictions on it, it can lead to a loss of bone mass. Moreover, it can lead to hyperoxaluria, due to the interaction between calcium and oxalate in the intestinal allo, which would lead to the formation of calcium oxalate complexes. In pharmacological treatment, as we have mentioned, we have stearic acid. Stearic acids are recommended by both American and European guidelines, and what they do is inhibit a sodium chloride cotransporter in the distal convoluted tubule, thereby enhancing calcium reabsorption directly in the distal tubule and indirectly in the proximal tubule. Here we have an example with hydrochlorothiazide, which acts by blocking that sodium chloride cotransporter. We know that hydrochlorothiazide is a thiazide of action. Short. Initially, doses of 25 mg per day should be used to reduce the potential complications that the drug may cause, although in many cases higher doses, up to 50 mg per day, may be needed. We also know that its effect diminishes over time, and the main side effect to emphasize in particular is hypokalemia, which is why potassium supplements often need to be provided or administered. Then we have the thiazide analogs, which are basically sulfonamide derivatives that have a longer duration of action, such as chlorthalidone or indapamide. It has been observed that imatinib, both in can also inhibit the sodium and chloride cotransporter, thereby reducing renal calcium excretion. And as a side effect, it is similar to hydrochlorothiazide. It can cause hypokalemia, and potassium supplements would need to be added. Another drug that can be used for hypercalciuria is amiloride, which is a potassium-sparing diuretic that works by blocking the sodium channel. And from there, it would promote increased calcium reabsorption at the level of the cortical collecting tubule and decrease potassium secretion. What happens is that amiloride has been found to have a slight hypocalciuric effect. And finally, it has also been observed that supplements with sodium bicarbonate or potassium citrate, which would rapidly metabolize to bicarbonate, can be given through a mechanism that is not known. It has been observed that raising the plasma bicarbonate concentration could increase calcium reabsorption, thus reducing its excretion. And then we would have potassium citrate, which will increase the pH, decrease bone resorption, and increase the renal reabsorption process of calcium. Since potassium citrate would act at the level of the pH-dependent calcium channel. In a study published in 2021, it was demonstrated that the effect of potassium citrate regarding its hypocalciuric effect is comparable to that of thiazide. And be cautious if potassium citrate is administered concomitantly with amiloride due to the risk of hyperkalemia that this entails. And that's it. Here is a bit of the bibliography used for this session. And that's it. Thank you very much.